Welcome everyone to KS&A's webinar, one of several in a series of members-only webinars. They're free to members. They're not for sale to anyone who is not a member. This one is with Dr. Peter Schlegel from Weill Cornell Medical College. Dr. Schlegel is part of a team of researchers and specialists who focus on fertility, among other things, but they focus on fertility. Dr. Schlegel works with Dr. Darius Biduk, and a number of years ago, in 2008, KS&A was fortunate enough to pass along a very generous gift from an individual donor, a $50,000 donation, to this team to do additional research on fertility. And as I mentioned previously, we have videos from a conference they did for us as part of this package in late 2007. So there's some very high quality material on those videos, which are accessible to all members. So without further ado, I am going to introduce Dr. Schlegel and give him control so that he can make the presentation. And thank you, Dr. Schlegel, for giving us your time and your experience. And you now have control.
Absolutely. Thank you, Jim. So what I'd like to go over is some of the experience that we have, which is primarily in treating adult males who have Klinefelter syndrome. And of course, that is part of a larger group that we've treated of men with severe fertility problems, and particularly emphasize what we see for Klinefelter patients, what we are now seeing as we look in greater detail and attempt to preserve fertility for adolescents with Klinefelter syndrome, and just the overall approach that is now what we consider sort of state-of-the-art, although is not treatment opportunities that are necessarily available throughout the country or around the world. This reflects both my work and the work of Darius Biduk. Most of it actually reflects what we have done in the individual treatment of patients. So we look at men with Klinefelter syndrome as clearly having significant issues with testicular and hormonal abnormalities. Almost all men with Klinefelter syndrome have small volume testes and relatively low circulating testosterone levels. And of course, testosterone is normally produced in the testes and then goes out into the circulation. In the past, it was previously considered that all men with Klinefelter syndrome were sterile, that they could not have children. Fortunately, a whole series of things have occurred, and a revolution of treatment options really exists for men with severe male infertility problems, men with very low sperm production or sperm production so low that no sperm appear in the ejaculate. And some of the treatments that have allowed us to help these men and with Klinefelter syndrome and others are assisted reproduction techniques. That really refers to any procedure that helps sperm and eggs come together. It involves in vitro fertilization, which is really bringing sperm and eggs together outside of the body. It is typically about a 6-week process. During the last 2 weeks, the woman receives a series of hormone injections to help optimize and stimulate the ovaries to produce multiple eggs. Those eggs are then extracted out of the body so that you're dealing with multiple eggs rather than the single egg that's normally ovulated each month, and sperm and eggs are brought together outside of the body. In vitro refers to in glassware, again, the fact that fertilization of sperm and eggs occurs outside of the body. ICSI is just a technique that's used during an IVF cycle, and it's the way that sperm and eggs are brought together. Specifically, it is intracytoplasmic sperm injection, meaning that a single sperm is injected into each egg during an IVF cycle, and this is an extremely effective way to take sperm, even if there are very limited numbers of sperm and relatively weak sperm, and help them to fertilize an egg. Fortunately, both of these techniques, both IVF and ICSI, have not been shown to result in a significant increase in birth defects or problems that occur, although certainly some men who have low sperm production may have genetic conditions that could be passed on to offspring, and I'll talk about that more a little bit later. The technique itself does not appear to increase risks of birth defects. So when we think about Klinefelter syndrome, 47 XXY males and their fertility, we know that all of these men have abnormal sperm production. Usually there are no sperm in the ejaculate, although up to 5% of men will have very rare sperm in the ejaculate, and particularly very young men with Klinefelter syndrome, that number appears to be slightly higher. So certainly, if we're talking about whether a Klinefelter male has fertility or not, or how he can be treated to provide fertility, a semen test needs to be done to very carefully evaluate for small numbers of sperm. Normally there's 80 to 100 million sperm in the ejaculate. We can deal with even 5 or 10 individual sperm in the ejaculate, so it's a very careful sort of analysis that needs to be done. At Cornell, a group of males that we deal with is those males who have sperm production that is so poor that no sperm are present in the ejaculate. In the past, we assumed that if no sperm were in the ejaculate and it was low production, that there would be no sperm in the testis as well, so these men were sterile. Turns out that that's not true. So this group of men together we referred to as having non-obstructive azoospermia. Azoospermia referring to the fact that there is no sperm in the ejaculate. Non-obstructive really means that it's not a blockage. It's not normal production with a blockage preventing sperm from coming out. It's really a matter of very low production. The sperm typically are weak, and it takes 7 to 10 days for sperm to come out of the body. So even if you have low production, that can be present and have no sperm in the ejaculate. Turns out that the majority of the men sort of globally with non-obstructive azoospermia, most of them have rare sites of sperm production. Surgery is needed to find and retrieve those sperm, and IVF and ICSI is needed to use those sperm. In some cases, you'll take the sperm out and freeze them and then later use IVF and ICSI, and sperm, once they're frozen, can be frozen for decades. The freeze-thaw process is really what causes damage potentially. It's not the period of time that sperm are frozen. When we try to treat adult males, we will typically do surgery together with IVF ICSI all at the same time to treat the couple at that point. So again, Klinefelter syndrome is one of the diagnoses or causes of low production we call non-obstructive azoospermia. So sometimes I'll talk about this NOA or non-obstructive azoospermia condition. That's really a generic term for the fertility problem that's present for most 47 XXY males. When we started looking at whether we could actually treat Klinefelter syndrome, we first were concerned about the potential hormonal issues that were present. We know that testosterone within the testicle is critical for sperm production. And testosterone levels in the testicle are usually 15 or 20-fold higher than in the circulation, because that's where the testosterone is built, it is produced, and it bathes the tubules, the area of the testicle where sperm are made. What we actually found in Klinefelter patients is that there's excess degradation of that testosterone to estrogens, and that degradation occurs by an enzyme that's referred to as aromatase. We actually found that we could reverse or prevent that degradation or breakdown of testosterone to estrogens by treating with a class of drugs called aromatase inhibitors. And that clearly is something that would optimize internal production of testosterone and can optimize circulating levels of testosterone. However, we know that higher circulating levels of testosterone are helpful both for behavioral issues as well as potentially for bone development and other normal functions, and in some cases may actually be necessary for some 47XXY men. Difficulty with giving testosterone from the outside is it shuts down the body's production of testosterone to some degree. And so if we're trying to optimize how the testicle works and how it makes sperm, in most cases, we don't want to use testosterone. When we think about what goes on with Klinefelter syndrome, there also appears to be at least a subtle effect of age on treatment success. So adolescents appear to have better sperm production than older males. Unfortunately, the data that we have for adolescents is relatively poor, and Dr. Paduch and myself are trying to rapidly put together as much information as possible about adolescents and where they stand. But the single article that suggests that production is better in young adolescent males actually indicates that the production may decrease dramatically after age 13. So there's a very narrow window before young adolescent males with 47XXY starting their sperm production and having it shut down. Sperm production doesn't shut down completely. Older men might have somewhat lower sperm production, but even the oldest men that we've tried to treat, we can get sperm and treat them at least 50% of the time.
Dr. Schlegel, this might be a good time to introduce a question from someone who asks about how the information you're reporting applies to those who are Mosaic.
Sure. So we have not usually seen significant difference between the non-Mosaic males and the Mosaic males in that actually our sperm retrieval rates are as good or better in the non-Mosaic males. What really is a determining factor in terms of sperm production and how the testicle works is what component of cells caused the testicle or allowed the testicle to develop. And in almost all of the Mosaic patients that we see, they look just the same as the non-Mosaic patients. So there's no gradation of sperm production. It's almost an on or off sort of thing where either the testicles don't develop or they're perfectly normal, and frankly, we don't end up seeing those patients. It may be that there are a few of them where the testes develop completely normally because they do have enough mosaicism, the testicle wasn't affected, but frankly, we almost never see that. Of course, the patients that we see are much more likely to have lower sperm production at baseline. So from a fertility standpoint, we really don't see a difference in non-Mosaic and Mosaic males. Let me move on to the next component. That talks a little more about these low circulating testosterone levels that we detect in most Klinefelter males. And we believe that that may reflect low intratesticular testosterone levels. And as I said, that intratesticular testosterone, having it bathe the sperm making areas, is pretty critical to helping sperm production work as well as it can. So one of the first things we decided to do is to see if we could treat or correct any hormone abnormalities to try and optimize sperm production before we went in and did invasive things like surgery to try and get sperm. So when you have low sperm production and low testosterone production, sometimes that's called testicular failure. Ways to stimulate the testicle could include clomiphene citrate, a drug that blocks the body's ability to sense estrogens. We could use HCG, which is a hormone that directly stimulates testosterone production in the testicle. Or we could use these aromatase inhibitors, class of drugs that prevents testosterone from being converted to estrogens. We particularly like to use these aromatase inhibitors when the testosterone level is low, and a cut point for a low testosterone is generally considered to be 300 nanograms per deciliter. But if the testosterone to estradiol ratio, a measure of the amount of conversion of testosterone to estrogens, is also low, that may be a particular situation where these aromatase inhibitors are more likely to function. So the goal of any of these medical therapies, which usually are only needed for a month or two, is to optimize intratesticular testosterone production, optimize sperm production prior to proceeding with sperm retrieval. Now, I have to say, there also is a potential to use these agents to bring the testosterone levels up instead of giving gels or injections or patches of testosterone from the outside, which again would tend to shut down sperm production. Let me just show on
about the aromatase inhibitors, and you may get to this, but whether or not the side effects such as change in growth height and so forth might be associated with aromatase inhibitors.
Because both testosterone and estrogens act on bone, early on there was some question or concern about whether aromatase inhibitors would affect bone development, bone density, and the ability to sort of cap off or close bone growth. And a very nice study that was done by one of the pediatric endocrinologists down in Florida looking at bone turnover products actually suggested that the aromatase inhibitors don't adversely affect bone density. So part of that probably is determined by which aromatase inhibitor that you use. Anastrozole, the one that we've used mostly, is still allows at least trace amounts of estrogen to be present in the circulation, and it therefore doesn't seem to have any significant effect on bone growth or development. So side effects from a bone standpoint don't appear to be a concern. Estrogens do appear in at least some males to be involved with libido or interest in sexual function. So 3 to 5% of males who are treated with aromatase inhibitors, even though their testosterone goes up fairly dramatically, about 3 to 5% will report some effects on libido. So there can be rare side effects, but they appear to be fairly limited. So the body normally functions by having hormone pulses released from a central part of the brain called the hypothalamus, going to the pituitary. This releases LH, which HCG as an injection sort of mimics. That acts on the hormone-making cells, what are called Leydig cells within the testicle, and they produce testosterone that both bathes the other areas of the testicle, the sperm-making areas, as well as releasing testosterone into the circulation. And the body actually senses the amount of testosterone that's present, both as the absolute amount of testosterone as well as the estrogens. So when we use a drug like an aromatase inhibitor that prevents testosterone from being converted to estrogens, the body senses that as having less testosterone that's actually present. It produces more LH, it produces more testosterone, and so you get higher testosterone levels and a net decrease in the estrogens or female hormone levels. Similarly, if you use the drug called clomiphene citrate as an estrogen receptor blocker blocks the pituitary's ability to sense estrogens, and again, The pituitary responds to that by making more LH. LH stimulates the testicle to make more testosterone, and you get more testosterone in the circulation. So both clomiphene and aromatase inhibitors, including anastrozole, are drugs that act by tricking the body's ability to sense or decreasing the amount of estrogen that's present, and thereby increasing the amount of testosterone, particularly the amount of testosterone within the testicle. And that's how and why we use those drugs. Effects on the prostate and other areas of the body are not particularly important because the levels of testosterone that we get are not high enough to significantly affect the prostate or other potential action areas within the body. Now, most of the men with Klinefelter syndrome, we're interested in optimizing them and sorting out where they stand. For the men with Klinefelter syndrome, we found in our early experience that you could do surgery and retrieve sperm from the testicle in 68 to 73% of those patients. So most of the men with Klinefelters actually have sperm within the testicles if you use a very effective search within the tissue of the testicle to find the sperm. For the men who are on testosterone treatment or testosterone replacement, so the body was sensing, let me just back up for a second. If you give testosterone from the outside, what you're doing is basically telling the body that there's enough testosterone here. That tells the pituitary to shut down hormone production. It stops making LH. And even though the circulating testosterone level is high, no more LH is produced because the pituitary doesn't make it, and therefore the testicle doesn't make the testosterone. It's coming from the injections or gels, and the testicle essentially withers and decreases sperm production because of a lack of internal production here. So we were concerned about that potentially occurring for men who are on testosterone replacement. We know that their intratesticular or internal or endogenous testosterone production was very low. And sure enough, when we looked back and saw how we did to retrieve sperm on these men, we found that we only found sperm in about a quarter of those men, far worse than the 2/3 or so that we would normally expect. So we're very concerned about this link between testosterone replacement and poor treatment results. So all patients who have Klinefelters, we stop their exogenous testosterone, consider treatment if the testosterone is low. Usually we'll start with an aromatase inhibitor like anastrozole, and if the response is inadequate, in other words, the testosterone does not come up enough, then we will further try and stimulate testes by adding injections of the HCG. We use the anastrozole first because it makes sense, but also because it's a pill. You just take one pill a day. It's a very simple sort of treatment, and only if the body doesn't respond, if we don't get adequate levels, do we then add the HCG injections. When we looked back and said, how do these testosterone levels relate to success? Well, when we considered men who either had sperm found or didn't have sperm found with Klinefelters, we found that the initial testosterone level was really not much different if you had sperm found or not sperm found. But remember, almost all of these patients with low testosterone levels we would treat. So after we treated them with anastrozole or other medications, we actually found that their response to treatment predicted pretty well the chance of sperm retrieval. You can also see that the testosterone levels, the internal testosterone levels, went up fairly dramatically on treatment from levels about 150. Remember, 250 to 300 is really the lower end of normal. So from 150 or so up to 220 to 320, sort of the responses that we would see. And the patients who went up the most were clearly those who are most likely to be successful in sperm retrieval. So this led us to believe that A, using medication enhanced the chance of sperm retrieval, and B, the response to medication to a large degree predicted which of the patients could be more successfully treated. Now, most other measures that we use to evaluate how the testicle works from the outside really don't help us in men who have non-obstructive azoospermia or Klinefelter syndrome as a whole. So, for example, the FSH hormone level, which reflects how the testicle works as a whole, does not predict at all the chance of sperm retrieval, particularly in Klinefelter syndrome. Similarly, testicular volume doesn't predict the chance of sperm retrieval. And the reason why those parameters that normally are tightly linked to how the testicle works don't provide any input or help at all is that these measures, the FSH hormone level and the volume of the testicle, really reflects the overall function of the testicle, not the focus of the most active sperm production within the testicle. And having one area of the testicle that makes sperm is all that's necessary to find sperm with surgery and be able to use it and allow fertility. So many times physicians will look at a patient, particularly a Klinefelter patient, they say his testes are too small, his FSH is too high to have any chance of fertility. There's no reason to do surgery or consider treatment. All of the patients that we treat have markedly abnormal FSH levels. All of the Klinefelter patients that we treat have similar and very low testicular volume. Neither of those features actually predicts the chance of success. Neither abnormality rules out an individual patient from potential treatment or a couple from potential fertility treatment. That is our experience. It's one of the largest experiences in the world, and it's been consistent over time. This is just a graphical depiction of what we see for men with non-obstructive azoospermia as a whole, which really reflects what I was just talking about. So these are all men with low production, so low that no sperm are in the ejaculate, so they need surgery. These are the FSH hormone levels, and remember, an FSH level for a normal male should be down around 2 or 3. 7 is the highest that's really normal in a young male. So these are all males that have moderate to marked to very marked elevations of FSH level. Despite those elevations of FSH, sperm retrieval rates are very consistent throughout. And if you made this graph just with Klinefelter patients, the curve would tend to be shifted to the right a little bit more, meaning the FSH levels overall are higher, but they don't predict sperm retrieval. Now, there are things that, different approaches that people have taken for sperm retrieval and different approaches for having children. And certainly before we talk about surgery and all these involved techniques, which also can be rather expensive, we certainly talk about donor sperm as an option for couples. If you go into the testicle and do what's called a biopsy, a single removal of a small area of tissue, you'll find sperm less than 20% of the time. If you do several biopsies, which actually tends to create a fair bit of scarring within the testicle, and that's called TESE or testicular sperm extraction, you can find sperm in 25 to 40% of men with non-obstructive azoospermia or the subset with Klinefelters. If you use a more detailed search that we refer to as Micro-TESE, you can get that retrieval rate for men with non-obstructive azoospermia as a whole up to 55% and up to 68% specifically for the subset of men who are 47 XXY. So when we talk about sperm retrieval or you talk about a biopsy, the details of that biopsy and the exact approach that's used, particularly with an operating microscope and a detailed search, and someone who has extensive experience with that procedure, can dramatically change the success rate in treatment. It turns out, if you sort of schematically look at what's going on within the testicle, men who have low sperm production typically have individual tubules being the area of the testicle that is supposed to be making sperm, individual tubules depicted here in black that make sperm, and the vast majority of the testicle doesn't work at all. So these patients, we're searching to try and find these individual sites where sperm are found, and the individual sites may be very limited. They can be just 2 or 3 or 4 sites per testicle, or they can be 1 site per testicle. But where they're present, they tend to be enlarging these tubules because these tubules have sperm production, these tubules don't. So the tubules with sperm production have far more cells within them. So these tubules tend to be larger or whiter or more opaque, and the difference between these tubules actually can be seen during surgery with an operating microscope. This was something of a chance event that we actually observed during these procedures. So I could see that many of these tubules, which are shown here, surrounded by the blue, are larger than the background tubules, which are empty because they don't have any sperm-making cells. The larger tubules are the ones with multiple sperm-making cells, and often those are the ones that have individual sperm within them. So the surgery is done both to search for these areas, identify, and remove them, and all of that needs to be done with very careful attention to preserving the blood supply, which can be seen within the testicle.
Dr. Schlegel, I have a sort of a two-part question here. Because we're moving beyond these, I thought I'd better get them in, and that is first, you appear not to recommend any use of testosterone therapy while proceeding with fertility options. Is that correct?
Well, that is a balance that needs to be sorted out for an individual patient, because individual patients may benefit greatly from testosterone. Certainly if any testosterone is used, what we want to do is try to avoid giving so much testosterone that you actually suppress the body's sensation of what's going on. So you can give a whiff of testosterone here as long as it's not so much that the body senses that it needs to decrease the LH and FSH that are stimulating the testicles. So there are ways to go ahead and monitor how much testosterone is being made by the body and how much suppression we're actually getting of the pituitary by following these LH and FSH levels. And in those males who require testosterone, if you're interested in fertility, it's best if you don't give so much testosterone that you suppress the system. Preferably, having fertility treatment or considering fertility treatment before starting testosterone at all may be an ideal approach, and that's why we like to have very early consideration of fertility and what we consider fertility preservation before you go on a long-term testosterone that may suppress this whole system and how it works.
So can you put a number to very early? That was the second part of the question. How young can you get started?
Probably in that 13 to 14-year-old age group is when you want to consider looking at this. Now, if an individual is 16 and they haven't been on testosterone, they haven't really lost anything, they probably are not at their peak level of production. But if you were ideally to say, when could we sort this out and when might we have the best chance of fertility preservation, it's probably the 13-year-old age group, far earlier than we would have thought in the past. I'll get into a little more data on that just a little later in the talk and the balance in dealing with adolescents and this whole approach. So this concept of going in surgically, finding little spots of sperm production and taking them out is done basically by opening the testicle and then looking at the tissue, following the natural blood supply and structures, And this can very safely be done in experienced hands and actually search through many areas of the testicle. The greatest risk of such a procedure is if you leave bleeding behind, and since you can actually see the blood vessels within the tissue and control them and prevent bleeding behind, you can often do this procedure with very limited effects on testosterone production, very limited amount of scar that occurs afterwards. So what I'm going to do is I'm going to show schematically in sort of a reconstruction what the surgery involves. It's a little bit graphic in terms of the general approach that we use, but I think it gives people an idea of how you search through the testicle and look at this whole process. Well, I will do that if it allows me to. So the incision is basically made in the scrotum, and the testicle itself is worked on. This is all done under general anesthesia, and the testicle is opened. You can avoid the blood vessels that are just underneath the surface of the testicle. Then you try to open and expose and examine the tissue. And there's some manipulation. You have to be very careful and gentle in doing this. You have to open and move the tissues around so that you can look in these different areas. But the tubules follow the same lines as the blood vessels shown in red here, and you can actually dissect or go between those tubules, preserving the blood supply to the rest of the testicle, and search until you see an area where the tubules are enlarged, those areas that are most likely to contain sperm. And you go ahead and separate that best tubule or area of the testicle that works best from the rest of the testicle. Sometimes you only need one or two of those. You take those out and look for individual sperm within the tissue. When we're treating adults, we will always do the sperm retrieval surgery or Micro-TESE with in vitro fertilization. We actually do the sperm retrieval surgery the day before the wife is having eggs retrieved, so we can work on that tissue and find the rare sperm. It involves a very tightly coordinated process of treatment for both the man and the woman. Processing of the specimens to find the sperm starts in the operating room. We actually have a technician right there who looks at them to see if we have sperm. And when we have sperm, we can see it in the operating room well over 90, almost 95% of cases. So we have an idea of what we have. We can stop the operation when we found the sperm that are necessary. We look at the adult males and their treatment. We have 114 attempts at sperm retrieval, and when I last put these data together, we actually found sperm, as I said before, in 78 out of 114, or 68% of attempts. Those sperm were then injected into the eggs, and in 66 attempts we were actually able to get embryos, fertilized eggs that were growing nicely and could be given back to the woman. And once sperm were obtained, pregnancy occurred, and by pregnancy I mean a fetal heartbeat that you can see on ultrasound in 42% of the cycles. If you count how many times you get a pregnancy when you took the embryos and transferred them back, it was actually a 52% pregnancy rate. 44 of these treatments have resulted in individual children being born. I should say 33 resulted in children being born. There were 44 total children born. All of them had normal karyotype when they were born. And it turns out that nature selects, even in a non-mosaic male, nature selects out sperm that are more normal, and the embryos are fertilized eggs that are more normal. So the rate of having a sperm with an extra X chromosome is 10%. The risk of having an embryo or fertilized egg with an extra X chromosome is about 5%, and the risk of having a child with an extra X chromosome is far less than 1%. So these are higher sperm retrieval rates than most groups have previously reported, but there is a very low risk of genetic abnormalities, and again it reflects a treatment process that is a little more refined than most groups are able to provide at this point in time. When we look back at the male age at the time of treatment, and I haven't included in here those under 21, but I'll talk about that in a minute. The sperm retrieval rate is quite high in those who are 21 to 30 as well as early 30s, and it seems to drop a little bit to about 50% for those who are over 36 years of age, but still about a 50% retrieval rate even in the oldest age group. So what about the adolescents? Well, again, the published information from Europe suggests, and unfortunately it's a very limited number of young boys are evaluated, suggests that the testis biopsies from the youngest adolescent boys, and that's really the 13-year-olds, have the best sperm production. At Cornell, Dr. Biduk has tried a cocktail of very low levels of testosterone from the outside plus the aromatase inhibitors together, and he's actually come up with a sperm retrieval rate of 78%, but unfortunately that's only 7 of 9 patients so far. So this is statistically no different from what we see in the males. It does suggest that you can give little bits of testosterone and still get reasonable results in terms of sperm retrieval, but we're not clear if we would do even better if we stayed away from testosterone alone.
Dr. Paducah, Dr. Schlegel.
Retrieving sperm in adolescence.
Sure. A timely question, and that is, in the case of an individual who's had testosterone therapy for some time, what happens if the individual suspends testo therapy for a period of time and then attempts to do assisted fertility procedures?
Sure. It appears that stopping that testosterone, or at least decreasing the testosterone and increasing the internal production of testosterone, is important for success in that in those patients who have previously had long-term testosterone. The difficulty is it may take a year to a year and a half if we look at males who have other similar hormone problems where they've been suppressed, like Coleman syndrome. It may take a year and a half, 2 years to optimally get those testicles to work again after they've had long-term testosterone suppression. So you can do it. It needs to be delicately done. You need to monitor to make sure that the pituitary, in essence, has woken back up again. And you can do that by monitoring LH levels, FSH levels, and an internal production of testosterone precursor called 17-hydroxyprogesterone. By monitoring those hormone levels, you can get a picture of when you've woken up the hormone system and how much of the testosterone that you see in a blood test is coming from the outside versus the inside. Obviously, the simplest way to do that is to stop testosterone completely, but most males who have had testosterone provided for a long period of time are going to take a little while to reawaken their system and are going to feel fairly crappy when their testosterone levels drop dramatically. And sometimes it could be other behavioral issues beyond just feeling poorly. We do getting them off of as much testosterone as possible, stimulating them and optimizing them for a year to year and a half, and then providing the fertility treatment with surgery and IVF. The sperm retrieval in adolescence can truly preserve fertility that may be lost later, but the sperm have to be frozen then, and sperm don't always survive freeze-thaw. So we certainly can use that. It often works very effectively, but it's hard to predict for an individual patient how well that's going to work. Earlier sperm retrieval does appear to be more successful, again, particularly in the early teens, but the approach overall may be limited somewhat by a lack of sperm survival. What we'll often do for a male who is going on to testosterone treatment is to try and look in one testicle, get sperm from that side, and then preserve the other testicle so that if later in life the sperm don't survive freeze-thaw, you can try and reawaken the other testicle and get it to function and have another shot as an adult, which normally we do pretty well in adults. Again, a little bit worse if testosterone production has been suppressed by giving testosterone from the outside. So what Dr. Paduch and I typically do is to evaluate sperm production very early. If the males often are able to provide semen specimens at age 13, it's a little bit tricky because nobody likes to talk about getting a sperm test from an individual that young, but most young men that we've seen are able to have that discussion and look at a semen analysis and consider early sperm retrieval if you don't have sperm in the ejaculate. As I said before, if early sperm retrieval is done, we usually limit that retrieval to one side, operating on just one testicle rather than both of them, as we'll do an adult, and that allows you to maintain the chance of sperm retrieval as an adult as well, where at least if you haven't had testosterone, we get a high retrieval rate overall. So in summary, fertility treatment is now possible for most men who are 47 XXY. Earlier treatment is probably ideal, at least in the early adolescent time, but even for the oldest group of males that we treat, we get at least a 50% success rate. Pre-treatment hormone optimization appears to encourage internal or endogenous testosterone and sperm production. Sperm retrieval with freezing is certainly an option, and the best results appear to be sperm retrieval and IVF together. And it is not clear how much you need to avoid testosterone treatment or just limit the testosterone treatment. We've certainly seen that males who have gel-based treatment tend to have much less suppression of their function of the testicle of sperm production than males who have had injection-based treatment, which of course is cheaper, simpler, and often easier for some males to do. But the gel-based treatment probably is better in terms of maintaining the ability of the testes to work, particularly in terms of sperm production. All of these results, particularly the ability to provide fertility, is really the results of a huge group at Cornell. There is an IVF team that is headed by Dr. Zev Rosenwax. There is a lab team that is headed by Dr. Zaninovic and Dr. Palermo, who actually invented the XXY technique, and all of the surgical procedure in adults I've done, and Darius has really been groundbreaking in a lot of his insights into how we can approach these adolescents and putting a lot of that data together. So that's sort of the formal presentation that I have, and I'd be happy to answer any questions that people have.
Just bringing my microphone back on. Thank you, Dr. Paduch. I'm very sorry. Thank you, Dr. Schlegel. There is a question that was posed here, and it might actually warrant a dialogue. A mom asked me, she's not able to actually talk, so I will relay her question. She asks, is it fair to say that all of these guys being put on testosterone therapy early on is doing them a disservice when they should be paying closer attention to their reproductive capabilities rather than just focusing on dealing with testosterone therapy from early years?
Well, I think that's a consideration. I think there are upsides and downsides to testosterone therapy. I think in the past, the pediatric endocrinologists and endocrinologists as a whole have focused exclusively on the benefits of testosterone therapy. And we have to consider that there are some downsides, there are some limitations in terms of fertility potential by going on testosterone. Most parents who have had a 47 XXY boy and had them treated with testosterone will swear by the apparent changes that they see that appear to be related to the testosterone treatment. I think we probably can get some of those benefits, but not over-treat those males and still preserve their fertility in a lot of cases. And again, Darius's data where he's given testosterone to a lot of these males, but in relatively low doses, I think is a reflection of how you can sort of sit on the balance between providing enough testosterone for normal function, or, as we've also done, just follow males for a period of time. Don't jump into initial treatment, but follow them for a period of time until they absolutely need the testosterone, and then give it at that point, preserving fertility as long as you can.
A follow-up to that, and it's a very difficult question, is what constitutes a little bit of testosterone, or how do you determine what dosage would be too much in the situation of preserving fertility?
Sure. So again, testosterone that's delivered with injections, where the injection really provides a much higher than normal or supraphysiologic dose for a couple of days afterwards, clearly is much more likely to suppress the system than gels, which are a much more regular and low dose sort of replacement. So gels are a better way to provide testosterone and avoid this suppression that can occur. Perhaps even more importantly, monitoring the patient so that you see what happens to LH levels, FSH levels, and make sure that the body isn't sensing there's too much testosterone may be equally important. That's tricky. It requires monitoring over a period of time. It requires a physician who is attuned to and considers that it's important not to suppress those FSH and LH levels, but frankly there are very few physicians in the country or the world who really understand how the testes work in terms of internal production of testosterone and sperm production and what can be done. You've got to have somebody who's really attuned to that and will follow your adolescent with you and follow into adulthood as well. So there's no absolute testosterone level that is too high or too low. It's really more how the body responds to that testosterone and senses it that's most important.
Okay. This question is, can you go back and repeat the statistics you were quoting regarding the low risk in genetic anomalies passed on to offspring?
Sure, absolutely. So if you're to use a statistical model that looks at what happens when you make sperm, you're starting from a 47 XXY cell and you're trying to make sperm, you would expect that 50% of the sperm would have an extra X chromosome, because the 47 XXY is split into actually two 23 X or Y cells and two cells that would have 24 an XX or XY. So the theoretical risk of having an abnormal sperm of the sperm that are made by non-mosaic Klinefelter males should be 50%. It turns out when we actually look at the sperm that the rate of having an extra chromosome in the sperm is only 10%. If those sperm then fertilize an egg, the egg starts to develop into an embryo, the rate of finding an extra X chromosome in those embryos is 5%. If we look at children who are born, or ongoing pregnancies, we find that the risk of having a child who has that extra X chromosome at the fetus or birth stage is less than 1%. And this is not unusual. If we look at fertility as a whole and how many abnormalities, how many absolute abnormal chromosome numbers are present in embryos, it's in the range of 30–35%, but the risk of having chromosomally abnormal children, children with the wrong number of chromosomes, is far less than 1%. So it's a natural selection that occurs in fertility, period, including fertility that is assisted in this way, and the risk of having a child with an extra X chromosome from fertility treatment is far less than 1%. And that assumes that the couple has not availed themselves of the technique that can be used to analyze individual embryos before they're transferred, which is called embryo biopsy, where you actually do a chromosome analysis on those embryos to see if they have the right complement of chromosomes or not. We don't do that sort of embryo biopsy in every case of treatment because there's about a 5% error rate in doing the test. The rate of finding abnormalities is only 5%, and some couples look at the male who is having fertility treatment and say having an extra X chromosome is not that bad a thing. Why lose any chance or risk losing any chance of having the embryos not survive the biopsy process or decreasing the chance of pregnancy when I was in pretty good shape until I came to fertility treatment with you?
Okay. The questions are coming quickly. This next one, it touches back on the issue of testosterone therapy, suspending it, and then coming back. And this mom wants to know why not begin testotherapy and then come back later when the young man is old enough, in terms of maturity, to be a father. Suspend the therapy and move on.
So we actually don't have good enough data to say for sure what the results of fertility treatment will be if you had testosterone and then suspend it. What we've looked at is we've looked at males who had testosterone treatment in the past and who had testosterone roughly up to the time of retrieval. And taking both of those groups of men together, that's where we get the 25% retrieval rate. So clearly a history of having testosterone may knock down your chances. It doesn't knock it out for all males. It may be better with the gels than the injections, but there is some adverse effect of being on testosterone, period. So the argument against it is you do change your fertility potential in the future, at least subtly, possibly dramatically, with some testosterone treatment, at least at the levels that have traditionally been used.
Another question is, I know that Dr. Paduch does a lot of the clinical work. Do you do some of the clinical work as well? Do you see the young boys and young men?
Absolutely.
Okay. Another question is, is the fertilization rate from sperm retrieved from KS men lower than it would be in other assisted fertilization processes, for individuals who do not have KS?
It does not appear to be. The fertilization rate is affected somewhat from using sperm from the testicle. So the chance that a sperm will actually fertilize an egg if the sperm came from the testicle is about 55–60%. The chance that a sperm will fertilize an egg if it comes from the ejaculate is closer to 70–75%. and the chance of a perfectly normal sperm from a man with completely normal levels of production tends to be closer to the 75–80% rate. The corresponding pregnancy rates, once you use sperm from the testicle, is about 45% when the sperm come from the testicle, about 50% when sperm come from the ejaculate, and 55% if the sperm are perfectly normal to begin with. So there's very subtle differences and probably not terribly relevant.
The last question from the audience at this point is, do you know other clinics around the United States, maybe even in Canada as well, because this questioner is from Canada. Do you know other clinics that can do the kind of work that you do with the kind of skill and finesse that you do elsewhere around?
Well, some of the information I've presented tonight has actually not even been presented at medical conferences. The data from Dr. Paduch and some of the integration of the adolescents that we've done is not available to other doctors around the world, so nobody knows about it. So unfortunately, there aren't other centers that really approach Klinefelter adolescents in exactly the same that we do, the way we do, and that's difficult. But there's certainly outstanding groups in Canada, for example, Keith Jarvie, Ethan Grober, who are at Mount Sinai in Toronto, doctors Peter Chen and Armand Zinni at McGill. And there are other individuals in the United States who have a lot of experience. Ron Swerdloff at UCLA, and unfortunately very few of them really focus on this issue of what can you do best for adolescents and for young males with 47 XXY.
One mom says, anybody in the Boston area?
In the Boston area, Bob Oates is probably the most thoughtful individual. He's at BU. Dr. Corey Tanricut at Mass General is also excellent. And those are really outstanding urologists who specialize in reproductive issues.
The next question is really from me, and this is going to be a mixture of a question and asking you to sort of vet or proofread the kind of counsel that I give out. The first part of it that I tell people is that fertility clinics are a dime a dozen, but this expertise is unique, and that you can spend a lot of money at any garden variety fertility clinic, all of whom do the TESE and ICSI and IVF, but that don't understand Klinefelter syndrome and don't understand the fine manipulation of the balance with testosterone. So that's my statement. Is that accurate?
Unfortunately, I think it is accurate, and I say that because of the following anecdotes. First of all, we see a lot of patients, almost half the patients that we treat have had failed treatment elsewhere, and that's disheartening for the patients. And I think one of the difficulties with these surgical interventions like biopsies is they don't tell you much about how the testicle works as a whole, and they do often create some scar tissue that can limit your chances in the future. So certainly going to a group that understands the potential for treatment is important. Also, when we look at the sperm that we've retrieved at Cornell, and sometimes couples try to go back to another center closer to home and use those sperm, even though they've reliably been used to fertilize eggs and allow pregnancies at our center, they're often discarded at these other centers because they just haven't dealt with enough patients who have Klinefelter syndrome. And I don't say that to drum up business for Cornell, but I believe that you've got to be pretty experienced, have a really good team in the lab, a great IVF team, and a reproductive urologist or doctors who have a better understanding of the testicle and how it works. And this very delicate balance of having a little bit of testosterone or enough testosterone but not shutting down the system is a very delicate balance. And Dr. Paduch and I, even being very aware of these issues, have great difficulty keeping kids in the right balance. And it is a bit of an art as well as a science in terms of how you provide that medical treatment.
There is a question from the audience, and that is, do you know anyone in the Dallas-Fort Worth area? It's a big country, and people are inclined to not want to travel.
Yeah, Dallas is tough. There's a couple of male fertility experts there, but frankly, I'm not sure how much work they do with Klinefelter syndrome. So there's Jeff Bush, B-U-C-H, and Ben Hendon, H-E-N-D-I-N, who are both in the Dallas area. There's also Larry Lipschultz in Houston, and unfortunately, the group at UT Southwestern with Gene Wilson, really on the endocrine side, are outstanding. Gene's one of the real pioneers in endocrine action and testosterone function, and the two of us have slightly different views about testosterone and action in the testicle and how you can keep things functioning. But he's a very bright person, although he tends to take a slightly different approach than we do in management of some of these young Klinefelter boys.
Back to my question, and I was surprised that you didn't mention XXY, and I've routinely touted those three procedures as a bundled package. So where, if at all, does XXY fit into this process?
Well, XXY really is the critical component of IVF that is necessary to use sperm. So when I initially described the XXY process and using it as part of IVF and then subsequently talked about IVF, I'm really implying that XXY is done during those IVF treatment cycles in every case where you've got rare sperm in the ejaculate or you're using sperm from the testicle. So when I used the generic term of IVF later, I was really implying that XXY would be used in every situation.
Terrific, thank you. It's really important to me that I not be misleading people.
No, you're exactly right. I've just used a little shorthand in discussing it.
I think the last question then is for someone who's going to do this, and I realize this is a very broad spectrum question, but what is the budget to do this kind of procedure once, and how often does it have to be done more than once?
Sure. So sperm retrieval can cost anywhere from $3,000 to $18,000, depending on what setting it's done in and how it's done. The IVF treatment can be $15,000 to $20,000, again, depending on where it's done and how it's done. And if you look at all components of treatment, and if you're successful everywhere from starting with buying your medications to a woman going through IVF treatment with stimulation and monitoring, laboratory fees, XXY process, sperm retrieval, egg retrieval, anesthesia, hospital charges, really everything soup to nuts at Cornell and you're successful at getting embryos back, your treatment cost is about $42,000 for that try. You may have sperm that are frozen from that could be used later. You may have embryos or fertilized eggs so that you don't have to go through hardly any of the process. You may end up needing to have the whole treatment repeated for a future attempt as well. So, you know, it is an involved and expensive treatment because we will have 20 or 25 people who are working to treat that woman, to produce multiple eggs, to search for the rare sperm that are present and process them, and to do these injections in ways that, you know, not every center can do. So it is an involved and expensive treatment process, but it can be very successful.
Well, Dr. Schlegel, I really, truly appreciate this. This is a very, very compelling and very clear presentation. I thank you very much. I'm going to take the screen back for now and let the audience see what is posted on the website in the link to set up your viewing of this webinar. There is a link to Dr. Schlegel's profile on the Weill Cornell Medical College website. So his contact information is there. And once again, I truly thank you. This was an excellent program, and remind everyone that the link to the clickable link to the handouts is here. You can have your own printed copy of all of these slides with all of the data and so forth, and within a week to 10 days we will have this posted on the website so that you'll be able to view it several times if you wish and go back and forth and actually review some of the specific detail that interests you. So thank you very much to all of you for attending, and thank you very much, Dr. Schlegel, and give my best to Dr. Biduk.
Will do. I got to say it has really been our pleasure to try to help all of these couples, and we're fortunate that we've been as effective as we have so far, but our goal is to continue to learn and optimize and improve these treatments as we go along, and hopefully everybody we treat and help allows us to do better in treating the next couple or the next individual that comes through. And by putting these data together and by using the funds from KS&A to look experimentally at how we can analyze how the testicle is working without doing surgery, gives us new opportunities to further help men in the future by doing less and less.
Well, I want to thank you again, and good night to all of you.
Thanks, Jim.